Non-sterile team members in the OR are the anesthesia provider, who also is part of the intra-op team, but also is a provider in the post-anesthesia care unit, or what you may have heard called the recovery room before. The circulating RN is also non-sterile. That is someone that can kind of move in and around the setting and bring things to the sterile team. You may have some additional unlicensed assistive personnel. And then in the suite and around, you'll have an OR director or manager that also can be there to assist with things. These are your priority assessments and procedures inside the OR before the patient before the case is started. While the patient is still awake and alert, they may evaluate again, their knowledge of the surgery complications. You may want to validate and confirm once again that the informed consent was obtained, and they again look at the patient's anxiety level, anything that they may have as concerns, so that if orders need to be addressed or changed during the case or forwarding through to the PACU, they're aware of those things. Again, they do the surgical pause, again to verify their that everything is correct in that setting as well. Surgical scrub is one of the most important things that they do prior to the case. Of course, it's to prevent surgical site infections. They have very strict hand hygiene and hand scrub procedures that must be attested to and done correctly. There's a very set way that they don their surgical attire. They have several levels of attire. They have scrubs, but they can't wear their own scrubs to the OR. These are scrubs that are sterilized and kept and provided from a laundry company, so that it doesn't have any of their own personal germs on anything. When they come in, they take off all their regular clothes and put them in a locker and don the scrubs that are just back there in that area, and then have additional garb and things that goes over that to keep the area very sterile during the case. This is just a picture that kind of shows some of that. You see how the person is doing the hand washing and letting the water run away from their hands to kind of take the germs as far away from the tips of the hands. Then there's the drying procedure following that, and then after that they've got to usually have assistants to put on some of their gloves and their gowns, and someone who is not sterile is likely the one behind them that's helping them with some of the tying and things. But this is sort of the process that your book outlines, and it's what you'll see how people are preparing in a case if you get to see one this semester. Anesthesia, in this day and age, most everybody has some type of anesthesia. The goals of anesthesia are amnesia, analgesia, depression of reflexes, muscle relaxation, and then really the ability to manipulate and manage the physiological systems and functions, vital signs, values. So those, and to keep everything stable. Amnesia, of course, is so that they forget what actually happened in there. Analgesia is, of course, pain management. You want depression of reflexes and muscle relaxation because you're getting ready to cut into tissue. You don't want it to have as much trauma to the area, and you don't want them to be jerking or moving in the middle of something that's really critical. These are the 4 types of anesthesia. You have general anesthesia. They will use drugs that are called volatile agents. That's just a listing of some of those. Muscle relaxants are also given, so someone may become physically paralyzed. And of course, the complications of general anesthesia, if you're paralyzed, then your respiratory status doesn't function on its own, and sometimes the person may get hypoxic. So typically with this type of situation, your patient's always going to have some type of ventilatory support. They're intubated so that they can have respiratory function offset with assisting them to breathe, either with a ventilator. And all of these things are key risk factors. They may get hypotensive or hypertensive depending on what's going on. They may get severe fluid electrolyte imbalances. They can have residual muscle paralysis following some of these drugs being given. Some neurological problems like dementia or prolonged awakening or strange sensations in their extremities or areas of the body. And then they can also have a severe complication called malignant hyperthermia. Malignant hyperthermia, they always nearly keep a kit in the OR setting, kind of like an emergent crash cart just for malignant hyperthermia. It is a life-threatening complication. It is associated with a genetic situation that makes people predisposed to it, and it begins with the skeletal muscle being exposed to a specific agent or drug, and when that happens, it causes this situation where they go into high, massive metabolism, and the calcium, levels jack up real high. They become acidotic with extremely high fevers and can have severe life-threatening dysrhythmias. So it is something to, that the anesthesiologist, of course, is, ask a lot of questions about prior surgeries and anybody in the family having ever had problems in OR, so that they kind of, are abreast to who might be at risk, as well as just having all the supplies and things needed to manage this should any of this occur. So here are some of the manifestations that you see here. Tachycardia, may have skin mottling, cyanosis, myoglobinuria, rise in the end-tidal CO2, and that's something that they measure with an apparatus connected to the ventilator tube, and of course very high elevated temperatures. Other types of anesthesia, you can have regional anesthesia, spinal, epidural, and then some direct nerve blocks that are given. This is just a picture of someone having an epidural done, and many people have that, of course, for childbirth, but it is also done a lot of times nowadays for surgeries that are on the abdomen, as well as GYN type procedures may have that as well. These are just some of the local anesthetics, the amides and the esters. Those are the drugs in the cane family. And lidocaine and bupivacaine are pretty common for being given at a local area that you're going to cut to just numb the area. It's kind of like when you go to the dentist and you get Novocaine, same kind of drug family. And cocaine sometimes is given orally to kind of numb the GI tract and the esophagus when you're doing endoscopies and things. And so, of course, with cocaine, you really want to watch for increased blood pressure and increased heart rate. I had a 82-year-old patient one time that they took down for an endoscopy, and they didn't want to give her anything to sedate her, so they just gave her oral cocaine, and she was wired for the rest of the day after that procedure. But you can just imagine how interesting that was. There is also monitored anesthesia care, which is considered conscious sedation. One of the drugs that often is given for that is Diprivan, and the patient may have a decreased level of consciousness. They may not remember anything about the procedure. It's important to kind of just maintain a patent airway. watch that, but generally they do very well with that, and they'll just respond. They may even respond to verbal commands and some physical stimulation, but then they just kind of go right back to sleep and they don't have a lot of memory of it. But that is one of the ways that they do some of the lesser procedures that are not so much invasive. When you have local or regional anesthesia, you can have anaphylaxis, which is a severe allergic reaction. You can have an incorrect delivery technique. A good example of that would be if you gave the medication but it just really didn't absorb, or it was given in the wrong area, and so then the area is not really numbed properly. You can give too much of something, and then they are so numb other organ systems like the lungs can be affected. And then sometimes you can have local complications where somebody just gets a really bad bleeding area or something that's caused from where the actual insertion site is. So treatment for any kinds of these severe things, of course, particularly for anaphylaxis, because that can have a respiratory component where it shuts down their airway. You want to make sure that the airway is open, make sure you're given oxygen, notify the surgeon immediately. A fast-acting barbiturate is usually the treatment of choice, and if they're having bradycardia or a very slow heart rate, they may give epinephrine to assist with that complication. Airway management, we've talked a little bit about when we had fundamentals, but airway compromise is caused by the relaxation of all the soft tissues of the oropharynx. So you also can, the other airway complications like a laryngospasm, if they've had bronchial, if they've been intubated but they went down too far in the bronchial tube, it can occlude off an area. They can also have a perforation of their trachea. Sometimes there are some types where they may have went in the wrong area and perforated an area of the esophagus. And of course, where they can have aspiration pretty easy because of the intubation and all the secretions that are not really being readily removed while they're under this case. I want to show you some pictures of some positioning in the OR, and you want to just make sure, I left a little detail in the notes here for the different descriptions of those, so I won't read those to you, but make sure that you go through and you're able to define a lateral, a prone, a jackknife, Trendelenburg, reverse Trendelenburg, and you'll see some different positions here too. It makes it a little bit easier to kind of visualize, how they may have them positioned on the surgical table. Different procedures are going to have a set normal way that they position them. Now, some of these cases take a very, very long period of time to get completed. So one of the key risk factors, and you want to remember this, you may see it again, is that patients that are restrained or positioned in a weird position, they are at high risk for skin breakdown, because you imagine you're clamped down on a table in a very weird situation for 4 hours during a case, and all your muscles are relaxed. So something may be really pressing and denting, situated in a way that would be very uncomfortable if you were awake. And then when you wake up, you've got severe pain in an area where the surgery wasn't even done, or skin breakdown can be severe sometimes from this as well. So here's some of the other positions that people may be in depending on what type of surgery that they have. And so imagine you're the one that has your legs up in the air for 2 hours. How if you've not been somebody that's been in that position for many years, that might be a real problem. But these are some of the complications. Make sure that you're familiar with all of those. And then other high-risk procedures, how long the procedure is, and some of these